Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and we're going to continue on with our Heart Health Month. Right now, it is looking like we're going to be talking today about all about navigating cardiac consultations and testing. I have Dr. Greg Koshkarian here with me. He is with Pima Heart and Vascular. Greg, you've done so many great talks for us. I'm so glad that you're going to sort of break down what happens, how you get, how you figure out what you need to do, because I know it can be really hard for folks. So thanks so much for being here today.
My pleasure. Thanks for inviting me, Maya.
So you do have an online audience that's watching along with an in-person audience. If you're watching from home, please go ahead and leave any questions in the chat and I will ask them after. I'll let you go ahead and get started.
All right, we good? All right. So this talk is less about a particular disease process. I've given talks about heart failure and other things like that before. And this is more like what to expect from a visit, what can you do to prepare for the visit, what kind of things might you expect the doctor would order. So purpose of visit is the important thing because that kind of guides the visit. Are you there because you're worried about some symptoms you're having? Are you there because a family member's had heart problems? Some people come in because their primary said you need to go in and they don't have any particular concerns themselves. But the purpose of the visit does help the cardiologist know where are we going with this. Purpose can be screening. So no symptoms, but you're worried about something going on with your heart. And again, there are certain things we do when we're looking to screen for disease. Symptoms are a frequent reason people come to cardiologists. We'll talk about the important information and know your heart problems because your history will also guide what the cardiologist may order. So starting off with screening, why are you there? What particularly concerns you? It's good to know how we cardiologists assess risk. A lot of people come in, for instance, and say, well, my grandfather died of a heart attack at 70 and my mother had bypass surgery when she was 80. And we cardiologists actually don't look at that as a particularly strong family history. Many people, if not most people, at some point develop heart disease as they get older. So family history of heart disease is considered if it is before the age of 55 in a man, before the age of 65 in a woman, and it's your first degree relatives that play the strongest genetic prediction for you. So we look at risks that include age, just getting older, it makes it more likely to have heart disease. We talked about the family history, smoking, high blood pressure, diabetes, cholesterol. Those are the kind of standard risk factors. And those are risk factors for coronary artery disease, blocked arteries. There are other risk factors for other conditions. For instance, congestive heart failure, weight, high blood pressure, inactivity. Those are things that play a greater role in the risk of developing congestive heart failure. So what are some of the screening tests? Sometimes we do stress tests. And by the way, later in the talk, I'm going to kind of go into the tests in greater detail. Lab work, knowing what your cholesterol level is. So we often check cholesterol. The higher the cholesterol, the higher the risk. Sometimes we'll check an inflammatory marker called a high sensitivity CRP. One of the probably most common tests I get nowadays, and probably for the last several years, is a coronary calcium CT scan. In some ways, that test isn't so much looking at a risk factor, it is actually finding the disease early on. So it's preclinical disease. Kind of everything else puts you at risk of having the disease. If you smoke, we don't know for sure that you have coronary artery disease, but you're at increased risk. If you have calcium in your arteries, it does actually mean you have plaque in your arteries. And so we now are doing that very often in screening situations. So symptoms. You're there for symptoms. What do you need to tell the doctor? You need to tell them the most important symptoms, what your particular concerns are. Because sometimes people come in and they'll say, I feel my heart skipping a beat, and the doctor might not think much of it. But it's important if you say, well, I'm scared because I heard that atrial fibrillation can cause a stroke, and so I'm worried I'm going to have a stroke from this. And then the doctor can kind of focus on the pattern of the skipped heartbeats and be able to say, yeah, I'm kind of worried about atrial fibrillation also, or, oh, this doesn't sound anything like atrial fibrillation. These kind of things aren't going to cause a stroke. So your symptoms and what you're concerned about are important for you to share with the doctor. What does the doctor need to know? Well, sometimes the doctor will redirect you. Sometimes people are giving more information than the doctor needs to know. And given busy days and lots of patients in the office, and you can see this gentleman with, it's only one page of questions, but it's probably the equivalent of about 20 pages there. So sometimes the doctor will interrupt, kind of redirect the conversation, try to get the specific information that he or she needs to get to be able to give you peace of mind or direction. All right, these are really the most common symptoms that people see cardiologists for. There's the category of chest pain or pressure. And interestingly, a lot of people will say to me, well, it's not pain, it's more just a pressure in my chest. Actually, pressure is much more suggestive of compromised blood flow to the heart than sharp pain. And that's not, in my years as a cardiologist for 30 years, I often find that people assume it's going to be really sharp and really severe, but heart pain isn't necessarily that. The other category is shortness of breath, whether it be shortness of breath that's waking people up from sleep, shortness of breath when they walk around. That's another kind of category of things. And then the other category is, and you might not think of these as categories, but we do because they all often relate to heart rhythm abnormalities, which is palpitations, dizziness, or frank fainting. Palpitations is not a diagnosis. It's a symptom of just you feeling your heart beating funny. So people who say, well, my heart skips beat, that's palpitations. My heart's racing, that's palpitations. My heart feels like a flutter sensation. Those are palpitations. So palpitations is anything that you feel that's unusual with your heartbeat. All right, so physician myth number one, we can't read minds. So you have to be kind of prepared to actually express what you're feeling. Often I'll come into the office when I see somebody, either a new person or established person, and say, hi, Mr. Jones, how are you? And or they'll say, how are you feeling? And they'll say, I don't know. That's why I'm here for you to tell me. And humorous, but I usually point out, I really don't know how you're feeling. You're going to have to tell me that yourself. All right, so let's go into some detail about how we look at these symptoms. Chest pressure, pain, we're going to ask, where is it? So for instance, left-sided discomfort in the chest is more suggestive of heart than right-sided discomfort. Does it travel anywhere? Traveling into jaw or down the arms is kind of stereotypically what angina does. How intense is it? And how does a person describe it? So quality makes a big difference. As I said a moment ago, pressure sensation is more concerning than it feels like somebody's sticking me with a needle. Heart pain does not ever feel like that. Onset, how long has it been going on? How frequent is it? How long does it last? These both help us assess whether we should be worried about it in terms of it being the heart. And even if we are pretty certain it's the heart, it also gives us an idea of stability. So for instance, somebody who says, I've had nonstop pain for the last 3 months, I've never without it. Heart doesn't do that. If you're having a heart attack after 20 minutes of pain, if you're having 20 minutes of pain from the heart, it's going to start being a heart attack at that point. And 3 months of heart attack pain, people don't make it through that. They usually go to the hospital though. So that kind of constancy. But let's say a person says, I'm having chest pressure whenever I'm walking around. Well, that's much more suggestive of being the heart. The pattern, it tells us how stable it is. If somebody says, I've been having that same symptom for the last year and it hasn't gotten any worse, still may be the heart, but at least I can say a person's pretty stable. But a person who says, a month ago I started having chest pressure when I was climbing stairs. 2 weeks ago it started happening whenever I walked across the room. Now it happens just sitting on the couch, and it's even worse when I'm walking across the room. That's an unstable person whose symptoms are getting worse and worse. So these are, again, the reasons why we ask such specific questions. Patients do sometimes feel frustrated, like, well, I don't know. I don't pay attention to how often it is or how long it is. And sometimes people don't know, but these are the reasons we ask those questions, because it's useful. What makes it better or worse? We kind of talked about activity making it better or worse is something that's suggestive of the heart. Now, turning the symptom of shortness of breath, kind of same thing. How long has it been going on? How severe is it? What is it that brings it on? Which again gives us some idea of the stability of it. Unlike chest pain or pressure, where you can ask somebody what is the quality of the pain, and it can differ from different types of things. Shortness of breath is kind of shortness of breath, and it's fairly similar whether it's coming from the lungs or from the heart. So usually we can't rule out one or the other, but often other questions we ask suggested. A person who says, I've been short of breath and it's gradually getting worse over 5 years, and I was diagnosed with COPD 4 years ago, and now I need oxygen, that person's shortness of breath is more likely to be from the lungs. But the quality of the shortness of breath is very similar to when it's from the heart. Nocturnal dyspnea, that means shortness of breath when you're lying down at night. Sometimes people actually wake up due to shortness of breath, or they can't lie flat. Some people say, I've been out of breath when I walk around and now I can't sleep without sitting up on a couple pillows or sitting in a chair. Those are potentially signs of congestive heart failure. And then symptoms, palpitations. I told you kind of different qualitative things that people describe, but just like everything else, we ask, when did it start? How often is it happening? How long do they last? People who say, I have an irregularity in my heartbeat, and say it feels like it skips. Once a minute, I feel a skip in my heartbeat, and the rest of the time it's regular. I can say that's not atrial fibrillation, that's a premature beat. But a person who says, I'm having skips in my heartbeat, in fact, it's so frequently that it just feels like it's skipping around all the time, that could be atrial fibrillation. Generally, we won't know until we do monitoring, but again, these are the kind of questions we'll ask to get some idea of whether to be concerned about it or not. We talked about the quality and the timing. Associated symptoms, palpitations that lead people to feel like they're going to faint are more worrisome than palpitations that don't really affect people in other ways. And then dizziness, fainting, all the other kinds of questions that we ask for every other symptom, we ask for that. One of the things that we specifically ask with dizziness and fainting is how suddenly does it occur, and does a person injure themselves? So people who faint, it's usually because there's not enough blood flow to the brain. And if you faint because you stand up too quickly and your blood pressure falls, the blood pressure fall is generally not instantaneous. There's usually a gradual drop in the blood pressure. And then people who faint with that usually will start to say, I felt myself getting a little lightheaded. And they'll often put their hands out before they fall. And they therefore won't as likely, land on their head and crack their head open. Whereas people who say, I felt perfectly fine, and the next thing I knew, I'm on the ground in a pool of blood and I've got a laceration on my skull, that's more concerning for an arrhythmia. So if the heart stops suddenly for, say, 8 or 9 seconds, the blood pressure, which is like this, suddenly does that. It's instantaneous loss of blood pressure, and thus instantaneous loss of blood to the brain, and a sudden fainting episode. And so people who faint suddenly and are injured, we are more worried that there's a pause in the heartbeat rather than just a gradual drop in the blood pressure. All right, physician myth number 2. Physicians' offices are not all linked. It would be nice if we were. If we lived in another country, they would be. There are national health systems where no matter where you go, a person's going to be able to access your records. But we're much more compartmentalized here in the US. And so when you have lab work done from your primary care physician or a scan of your heart done, and then you're referred to the cardiologist, you can't assume that the cardiologist is going to be able to access that. If we're all lucky, the referring provider will have sent this information, but a lot of times things get lost in the translation. So it is good, to assume that we might not have the information, and therefore be prepared to kind of answer, well, what did it show? What was it that the doctor was concerned about? Or even better, bring copies of things. So if your doctor says, I don't like the looks of your EKG, I want you to see Dr. Koshkarian, ask her for a copy of the EKG and bring it with you, and then you'll know that I have it. Okay, so things to remember to bring with you. A list of your medicines with the doses. A lot of people don't know what medicines they're taking. I would bet a very high percentage of people here have lists of their medicines. You're a more selected group of people that want to come to this kind of thing, but I'd say half the patients I see in the office don't know what they're taking and don't have a list of what they're taking. What tests have you had of your heart before? Some people come in, they've moved from out of town, or they're transferring from another cardiology practice, and they say, well, I've had 2 heart attacks, and one of the times they put a stent in. It's good to either have copies of the cath report that tells where the stent was put and what the anatomy of the heart vessels is, or at least know what hospital it was done at so that we can obtain that. Talked about cardiac or vascular procedures, and in order to get these records, the names of doctors and their contact information. Again, a lot of people move here and say, yep, you can call Dr. Johnson in Wichita and he'll have everything. But some people say, I had this done somewhere in Pennsylvania about 5 years ago. I'm not quite sure where it was. Like, I'm not going to be able to get that information. And previous hospitalizations. So these are all very helpful things for you to have with you when you go to that first visit. All right, so now we're going to turn to cardiac testing. So testing has different purposes depending on the symptoms and the situation. And again, we talked about there's tests that more towards screening, tests for, which includes prognosis. So screening is looking for disease, but it's also for looking at risk. How much at risk are you? And then there's more tests for diagnosing symptoms. So we don't do, for instance, cardiac catheterizations because a person says, I'm worried about my heart and I'd like to know how things are. I'm like, well, come over to the cath lab, we'll put some catheters in you. That's not a screening test. So in these pictures here on the far left is an EKG. Virtually everybody who goes to a cardiologist will get an EKG. The second image is an ultrasound of the heart called an echocardiogram. Pretty common for us to do, not in everybody, it's not an automatic thing, but it serves lots of purposes. The next image there, it's something you probably maybe haven't seen pictures of, but you've heard of, is some type of nuclear stress test. So nuclear stress tests give a nuclear isotope. It goes to parts of the heart that are getting good blood supply and doesn't go to parts of the heart that aren't. And you get these kind of images. And the first couple rows are what we call short axis views, where the imaging is sort of like little slices of the heart, looking at it like that. The other two are looking at the heart either in this angle or in that angle. So we get all sorts of different views of the heart and can tell what parts are getting good blood flow and what parts aren't. And the final picture is a coronary angiogram. That is the left coronary artery. And this is a person actually who has a pretty normal looking artery. People often ask, how many vessels do we have? We have generally 2 vessels that come off the aorta to supply the heart with blood. But then there's lots of branches, so you can kind of see how these vessels branch. So we have as many vessels as you feel like counting to whatever level. It's like saying, how many branches are there on a tree? Well, if you are only looking for 1 foot wide branches, maybe only 3. But if you're looking at 1 inch branches, there's hundreds. All right, so screening and assessing prognosis, trying to predict the future. We can't really predict the future, but we can give you some odds of what might happen. So when we're screening people, we take a history, we listen to the person, physical exam, vital signs include blood pressure and pulse. Again, we ask questions about your family history. Do you have diabetes? We weigh you, we ask about your activity and your tobacco use. So this is all collected information that kind of goes into what we call demographics. Demographics is sort of the things about you that are predictive of what could happen to you in the future and what disease processes you might have. As I said, everybody gets an EKG. An EKG can show if you're like having chest pain at that moment. An EKG might indicate that there is compromised blood flow. Most of the time, an EKG isn't going to tell you, yes, your symptoms are from blocked arteries, but some people come in who've had recent pain and they have such clear abnormalities on their EKG that we can pretty confidently say you've got some blocked arteries and you're unstable. Anecdotally, I had a patient about 15, 20 years ago. I got called in into the emergency room. The person was having chest pain. The ER physician called me. He said, God, this guy's having such a great story for a heart attack. I mean, he's got all the clear symptoms, but his EKG is totally normal. And so he shows me the EKG. It's totally normal. And I go and talk to the guy, and he's kind of talking to me calmly. And then he sort of turns white, and he's like, oh my God, it's happening again. And I asked him, I said, were you having pain when that EKG was done? He said, no, I was not having pain. So did an EKG, and the EKG had changed dramatically. It was clear he was having an acute heart attack. So EKGs are good to get, but unless you're in the process of having something bad happening, you can't rule out blocked arteries just from a regular EKG. EKGs can show previous heart attacks. There are voltage changes on an EKG that can tell us if there's enlargement. Labs, we talked a little bit before, we always check cholesterol. And when I say we check, most people have had these labs already done by their primary care provider. So these are kind of the ones that we cardiologists focus on. So a full lipid panel, cholesterol, a hemoglobin A1C, which indicates whether you have diabetes or not. And again, sometimes we'll do inflammatory markers like an hsCRP. In terms of screening, I told you earlier, CT calcium scan is something we often do. It's useful for people at intermediate risk. So if you come in and you're a 30-year-old man or woman without many risk factors, and you say, well, my blood pressure is a little high. I want to know if I'm at risk of having a heart attack someday. I heard these coronary calcium CT scans are good. I'm not going to order one on that person. They are literally 99.9% likely to be completely normal. So it's kind of a waste of their money. At the other extreme, a person who is 70 years old and says, I had bypass surgery 5 years ago, and I had a stent placed a year ago, and I've got diabetes, and unfortunately I still smoke, and I want to do a calcium score to see if I really need to be on the statin medication. No, I can tell you that without a calcium CT scan that you need to still be on your statin medication. But for the intermediate people, a typical person might be 60-year-old woman who says her mom had a heart attack at the age of 55, and she's on medicine for blood pressure, and her cholesterol is elevated, and she is wondering, would it be a good idea to be on medication, or should I just improve my diet? That's somebody who a calcium CT scan would be good for. And this is what it looks like when we get the report on the right. Some of the places you go will actually see images like on the left, where those images, where you see white there, that's calcium. In this scan, most of the calcium is in one vessel, but you can have calcium in all sorts of different vessels. One of the important things to know is we look at the global score. The specific vessel that has the most calcium is not necessarily the vessel that has the worst blockage in it. So a calcium score doesn't say how narrow the vessel is. Think of it as if you could scrape off all the plaque in your arteries of your heart and put in a little pile, the calcium score is proportionate to how big that pile is. And heart attacks are predicted by how much plaque you have, how many vessels you have. A person with, and this wouldn't really happen this way, but let's say you have 180% blockage and everything else is normal. That's not usually the case, but let's just say that for the sake of argument. And you compare that to a person who's got 40% blockages. The person with 40% blockages is much more likely to have a heart attack than the person with 180% blockage. Because heart attacks occur when a plaque suddenly becomes unstable, breaks, and that activates the clotting cascade and the vessel clots off. So the more plaques you have, the more likely one of them might do that. So that's why a calcium score is looking at your risk overall. It's not looking at anatomically, you've got a problem here, you've got a problem there. All right, so other cardiac testing we do for making a diagnosis, we already talked about the history and physical, EKG, labs. Stress tests come in a few different varieties. Some stress tests, you walk on a treadmill. Some stress tests, you use a chemical to induce the stress. And there are different imaging modalities. And you can kind of mix and match these in either way. So you can do a treadmill test with an echo, you can do a treadmill test with nuclear imaging. You can do a chemical nuclear imaging test, and you can do a chemical echo test. A treadmill can also be done all by itself without any imaging. And in people who can exercise well and have an EKG that is normal and readily interpretable, that's usually the way to go. But EKGs that start off with abnormalities at baseline often will become abnormal when you exercise, even if it doesn't mean a problem. So if we see abnormalities to start with, we'll usually do a stress test with imaging. And then there's different types of monitors we have people wear for some diagnoses. We have monitors that can be worn anywhere from 24 hours to a month. There are longer term monitoring. Some people have Apple Watches where you can not only be alerted that your heart rate went up, but you can actually push the crown and get an EKG. And if any of you have Apple Watches and didn't know that you can actually give yourself a little EKG, then look online or go to the Apple Store and have them teach you how to do that. Cardia is a new gizmo that we've been using a lot. It's a little metal plate. You put your fingers on it and it generates an EKG, and the information goes to an app on your phone. We give them to people in the office and then it gets transmitted to us, but you can buy them on your own. There are two kinds that they sell, at least on Amazon. One's called a one-channel one or a single-channel one, and another is a six-channel one. This single channel just has a single tracing of the EKG. Six-channel one has 6 different views. Think of it like when we do an EKG, that's a 12-lead EKG. There are 12 little vantage points that we can see the electrical activity from. The Cardia device can actually generate a 6-channel one, but it's a bit more expensive. The last time I looked, it was $130 versus about $80 or $90 for the single one. The advantage of the six-channel is sometimes it's hard to interpret a single lead. The electrical forces may not be prominent enough to notice it in that particular lead. And if you have 5 other leads, you may see things that you wouldn't have appreciated from the single lead. And then there's implantable loop recorders that can be put in for, indefinitely, but they have battery lives of 3 to 4 years, and they'll record the electrical activity over that period of time. So this is a stress test. This gentleman probably shouldn't have been put on the treadmill. His heart rate goes up to 202 just getting on there. Most people look a bit more like this and look a little more comfortable getting onto the treadmill. We try not to put people on treadmills who are so out of shape. And then these are different monitors. So the one on the left is the one we use at Pima Heart. It can be worn anywhere from 1 day to 30 days. And you can see how big it is. It gets stuck on your chest right over the heart. It's waterproof, so you can wear it, for 30 days. Not too cumbersome. The 1 through 3 day ones store all the information, whereas if you wear it for a week to a month, it actually transmits information. There's not enough physical space on it to store every heartbeat for a full week or a full month. And then the next image is what the Cardia device looks like. The image after that is the Apple Watch, and you can see how it's generating a little EKG tracing there. And the final image is the loop recorder I told you. So it's pretty small. It's relatively flat. They make a little nick in the skin. They slide it right under the skin, and it kind of passively watches your heart for several years. And then there's a bedside device that you have. It will send information to your cardiologist once a month or alert us if there's something more concerning that's happened. All right, so other tests we do echocardiograms. Transthoracic means the sound waves go across the thorax, so it's a little ultrasound probe that's put on your skin, looks at your heart. Transesophageal echo is in special situations where you need better imaging of certain structures, actually numb up the back of your throat and you swallow the probe. The food pipe, the esophagus, sits right against the heart, so there's very little tissue it has to penetrate, whereas the transthoracic has to go through bone and muscle, lung tissue, so the images aren't as nice as you can get. But obviously it's a lot more involved to do a transesophageal echo. People need to be sedated, so we do that in the hospital setting, not in the office. And then cardiac catheterizations, we can put catheters through a vein up into the right side of the heart to measure pressures. We can put a catheter in the artery up into the left side of the heart and also measure pressure and take pictures of the heart muscle. And then we can do coronary angiograms where we put the catheter into each of the right and left coronary arteries and inject dye. And you saw an image of that earlier. And then to the right is an image of a cardiac CTA. So we can do angiograms now with CAT scans. This image is very perfect. It's not as perfect always as we would like, and so it's why we don't always do this. We often do a cardiac catheterization, but in the right type of people, I generally find that a CT scan, cardiac CTA, is helpful in people that I'm kind of thinking are likely to not have blockage, because if the arteries looks normal or close to normal, we can be pretty confident of that. Whereas if we think they're highly likely to have blockage, it's just going to be one step toward getting the other kind of test. People have very high calcium scores. We don't tend to do a cardiac CTA because the calcium sort of fractionates the images and you get these sort of scattering effects and you can't really see the vessels very well. So this is kind of technical, but it's one way of saying there are reasons why your cardiologist may choose to do the non-invasive versus the invasive. So choosing the right test. People, and now we're back to those three categories of symptoms, and this is why I lump them together like this. So if you have chest pain or pressure, of course, you get the EKG, and we usually do some type of stress test. And the choice of stress test partly relates to whether the EKG is normal, not normal, if a person can walk on a treadmill or not. And as I said, sometimes we see such dramatic abnormalities on the resting EKG that we go directly to an angiogram. But a lot of times the angiogram, or most of the time I would say the coronary angiogram, is done after a person's had a stress test that is abnormal. Then for shortness of breath, all the same tests can potentially be used, but there's a particular lab we check to look for congestive heart failure. It's called a BNP or a proBNP. When the heart is stretched, it releases BNP or proBNP. They're kind of similar versions of each other into the bloodstream. And so we can measure that and say, oh, you're having fluid retention. The heart is being stretched and that released more of that into the bloodstream. And so that's helpful in evaluating shortness of breath. And virtually everybody with shortness of breath that might be cardiac, we get an echocardiogram, because then we can see how the heart functions, how it pumps. We can measure pressures in the lungs. We can look at the valves, whether they're not opening well, whether they're not closing well. And then there's other parameters we can look at. So echoes are very helpful. And then for the palpitations, dizziness, fainting, mainly we want to capture an episode. So we will get some type of monitor, and the duration of the monitor kind of depends on how frequently a person has it. Somebody who says, I'm having palpitations once a month, I'm not going to put a 24-hour monitor on them. A lot of times people have palpitations or even fainting, and it's so infrequent that no monitor is going to pick it up, and we're not worried enough about it to say put the implantable monitor in. And a lot of times we'll do an echo and a stress test, not because that will tell us what the palpitations are from, but it's helpful prognostically. It'll help us know, should we be worried about the palpitations or not? So somebody who let's say has had a couple fainting episodes in the last 2 years. One of them occurred on a really hot day and they thought they were dehydrated. Another occurred when they were at the doctor's office and hadn't eaten and had their blood drawn. So we think probably that's a benign cause of fainting called a vagal episode. But we're going to get an echo and a stress test to make sure your heart looks healthy and isn't the kind of heart that would be likely to have a dangerous heart rhythm. So we often use it in that way. So in summary, know the purpose of your visit before you go so you can tell the cardiologist what you're worried about. Think about what your symptoms are ahead of time and be prepared for a lot of detailed questions about when it started and how long it lasts and what situations it occurs in. Bring your medicines, bring old records, have contact information, and another pair of ears never hurts. It really is helpful to have son, daughter, spouse, somebody who not only might remember things that you don't remember, but will also hear what the doctor has to say so that if you kind of forget, what did he say about why I'm getting this monitor, you'll have another pair of ears to hear that. So cardiac testing shouldn't be scary.
So thanks so much, Greg. I love all the cartoons in there. It's always great to see. I've got a couple of questions that came in. One asked if you go to the cardiologist, will they automatically do and I'm probably not saying this correctly, so I want to make sure. I'm going to call it the APOB test and the LPA test automatically if you ask them for those. And maybe you can explain what those are for the folks watching from home too.
So a cholesterol panel, the routine one includes your total cholesterol, your triglycerides, your LDL, your HDL, but there are more sophisticated looks at your cholesterol profile that includes what's called an ApoB level. That's a protein, and every bad particle of your cholesterol is attached to an ApoB. So an ApoB level is another way of looking at what your lipid risk is. Everything but HDL is bad, and ApoB will kind of look at how many particles you have. The other reason you might say, well, why not just measure your non-HDL cholesterol? And we do actually do that. This is a little involved, but when we measure cholesterol, we're measuring volume of cholesterol, like you're measuring kind of the concentration of cholesterol in the bloodstream. But the body's response to cholesterol isn't really related to cholesterol mass, it's related to particles. So for the sake of argument, let's say you have a bad cholesterol level of 100, and each particle is 1, so that you have 100 particles. But let's say you have smaller particles, and each of your particles is 3/4 of the size of 1. That measurement of 100 divided by 0.75 would be 1.2. So you've got 120 particles, not just 100 particles. And we don't easily measure particle size, but if you could know how many particles you have, you would know your risk might be higher or lower. And so an ApoB level actually is indirectly a measure of how many particles you have. It's not routinely measured. You have to have special tests to measure it, but it can give extra information. So situations where a person has a family history of heart disease and they say, well, my cholesterol is really not that bad, we might find, but your particle number is high, your ApoB is high. Another thing that you can measure is something called an Lp(a) level. That is a specific molecule that kind of looks like an LDL particle, but it has an extra thing attached to it that not only makes it atherogenic, so atherogenic means causing atherosclerosis, causing plaque development, it also causes inflammation, and it tends to accentuate the tendency to clot. So Lp(a) levels are another thing that tell you more about your risk than just knowing your cholesterol. And unfortunately, we can't currently treat Lp(a)s. There's a lot of trials going on right now. In fact, we're doing one at Pima Heart that is looking at drugs that will lower Lp(a) levels. So right now, we're not checking it routinely, mainly because there's not a lot we can do about it, but it is still helpful prognostically for very similar reasons. Someone whose risk doesn't seem to be all that high, but it has a very high Lp(a) level, we might treat more aggressively for their other risk factors.
Great. So would they do the ApoB? Would they do that if you asked them to, or not necessarily?
I mean, of course, I can't speak for all the cardiologists.
Sure.
I mean, generally, if somebody asks for it, we'll order it. But it will also depend on, this gets into what is the person worried about? Why are they at the visit? And so for some people, I might say, I can order this, but I don't think it's going to change a lot of what we do. Again, a person with known blocked arteries, bypass surgery, stents, who we're trying to get their cholesterol as low as possible, knowing the ApoB is more of a curiosity thing. Like, okay, I also want to know this, but it won't tend to make us say, we don't need to lower your cholesterol anymore.
Okay. Yeah. We're not changing necessarily the trajectory of what we're doing. We had a session yesterday about cardiac rehab, and a question came up that was asked here about if you cannot do the stress test on the treadmill, what are the alternatives to that?
So for testing purposes, it's usually a chemical stress test. We do nuclear scans at Pima Heart. We also do PET scans, which is kind of a more accurate version of a regular nuclear stress test. But for exercise purposes, that's kind of a different kind of question. If a person says, I have trouble walking because I've got hip pain or knee problems, there are other types of exercise that a person can often do, even with problems that would limit them being on a treadmill or walking. Stationary bikes, rowing machines, things where your knees and hips aren't bearing all of your weight, water aerobics, things like that. So those are alternatives for exercise. There are chemical stress tests for people who can't exercise on a treadmill for testing purposes.
Okay, great. Now, I do want to put up your phone number so that people have it at home. I know you had it on the last slide, but it may have gone by too quickly for everyone. For an appointment at Pima Heart Vascular, please call 520-838-3540. So I want to thank you so much for being here today. I am going to wrap up with our online audience, and I'll turn it over to you for any questions in person. Thanks for being here.
Thanks, Maya. Nice to see you again.
Thanks. Thanks again for joining us today. We hope you'll come back next week. We've got Understanding Pulmonary Embolisms, Causes, Symptoms, and Treatment. That is with Dr. Vijay Doraiswamy on Tuesday, February 18th at 3 p.m. If you're interested in that class, please give us a call. Our phone number is 520-324-1960. We have spaces available in person as well as online. We'd be happy to get you registered for that. We hope to see you again next week, and take care.